So up till now, we have discussed all the shortness of breath cases. We have, there's a table here in the clinchers file, if you can see. It's going to demonstrate all the differences that's in between the four or five cases that we've discovered, that we have not discovered, that we have just discussed. I'm sorry. Anyway, so you see here, the first case is, let's say the patient has presented with talking. The patient was talking, his mouth was clear, just the saturations were low. We put him oxygen. We saw that there was a wheeze and decreased air entry. We ordered a chest x-ray. We saw that the patient has already had history of asthma, let's say. So we gave him salbutamol and ipratropium bromide. We considered other medications as well, like we have discussed before. We checked his disability, we checked the exposure, and we did this SBAR. This table is likely for your, just a quick revision when you have to discuss, when you have to revise all the cases together. Then we had the COPD case in which we put the patient on venturi mask. You see there are these color-coded clinchers where you see the differences between how to approach the case differently than the previous case. So in COPD, we used the venturi mask. We did not repeat the salbutamol. We just gave it. In the next step, we gave the ipratropium with the nebulization of salbutamol, and we did consider oral antibiotics. We did consider antibiotics as well. And we also considered oral prednisolone in this patient. The third would be, what is it? Yeah, anaphylaxis case where the patient was having difficulty. We did put the patient on oxygen levels. But before that, what we did was detach the patient from any blood, any antibiotic, any catheter that was placed with it. And we gave patient IM adrenaline. And we gave him fluid because of low blood pressure. We considered chlorpheniramine if the patient was having any rash, and we did give him hydrocortisone 200 milligram IV. Then we did our SBAR. Then we had the heart failure cases here. The chronic heart failure, GP referral, and the acute pulmonary edema case is the same. You give GTN if the patient's blood pressure is greater than 100 systolic blood pressure, and you give IV furosemide if the patient is having crackles in his lungs, which is because of the pulmonary edema, and then you escalate the patient to cardiology if needed. The last would be atrial fibrillation. You do mention IV furosemide if you're having a finding of crackles. If there's no finding of crackles, you don't need to mention the IV furosemide. And if there's irregular pulse on the monitor, or if when you're looking for pulse and you mention, I'm going to have a look at the pulse of my patient, and the examiner give you the finding that the pulse is irregular, quickly look towards the monitor, you see that the pulse is irregular. The rhythm shows atrial fibrillation. You do verbalize it. I suspect my patient is having atrial fibrillation due to IHD. So I'll be consulting with my senior and giving him 500 microgram of IV digoxin. That's it. And you just verbalize, complete all of your SBAR. The only differences between these cases is the management in some cases, as well as the kind of some blood tests you might be sending. In some scenarios, you'll just be sending the regular ones. In some, you'll be sending inflammatory markers. In some, you'll be sending troponin markers as well as proBNP levels. So do remember what you have to send in what particular case. That's it. I guess we're done with our shortness of breath cases. Now we're going to start the next segment. So if you have any question, please drop them in the chat box and I'll answer them.